Good morning. Thanks for coming today, and hello to all of our friends on Facebook Live this morning. My name's Don Yakel, like Michael told you. I'm an interventional cardiologist. I've been practicing since 1996. I spent most of my initial years down in Springfield. I was with the SIU School of Medicine as an associate professor there, and also with the Springfield Clinic. Just a little bit about myself from before that. I did my undergraduate at the University of California, Davis, where I was playing college tennis and kind of had dreams of being a professional tennis player, but after playing some of the folks like, not John McEnroe, but his brother Pat and some of those folks that played out in California at Stanford and such and getting wiped off the court pretty bad, I figured I better go into something else. So I went into biology and then did my medical school training at Wake Forest University, did my internal medicine residency at the University of Utah, where I learned to ski a lot better than I was before, and then finished up my cardiology training in San Francisco at the University of California, San Francisco.
Can you speak up a little bit on that? We can't hear.
How's that? We were worried about that. So I'll speak closer to the mic. So I was at the University of California, San Francisco from 93 to 96, and then came, after of course being in North Carolina and then California, the natural next stop was of course the Midwest. Springfield's a little topographically challenged, but after being there for 20 years, I've joined the group here at UnityPoint Health, where we've grown to 13 cardiologists with 4 interventionalists. And we're going to talk this morning about cardiovascular disease and some basics for y'all about how to decrease your chance of getting more cardiovascular disease if you've already got it, or how to prevent it if you don't already have it. So this presentation is designed for anyone interested in learning more about cardiovascular disease. Cardiovascular disease includes blockages in heart arteries, or what we call atherosclerosis, and coronary artery disease, structural heart disease, which includes problems with the heart valves, the heart muscle, the pumping chambers, and also blood clots in the heart, and that would relate more to atrial fibrillation. We're going to focus this morning just on coronary artery disease and atherosclerosis more, and blockages in the heart arteries. Of course, nothing replaces a heart-to-heart talk with your physician. I assume everybody in here has either a primary care doctor, or if you've got coronary artery disease, you've probably got a cardiologist, and usually we see folks every 6 to 12 months where we would do standard lab tests, and we'll talk about some of the tests that we might do on a yearly or every other year basis. So what we will learn today. So what is cardiovascular disease? We kind of touched on that, but what we're really talking about today is the types of fatty deposits and blockages that develop in heart arteries, can also develop in your neck arteries, which is called carotid artery disease or stenosis, and also in your legs, especially for folks that smoke, and that's peripheral arterial disease. So how is coronary artery disease diagnosed? We're also going to go over treatment of coronary artery disease, including possible lifestyle changes, medications, procedures that are done to fix a blockage once you got them, and some of the warning signs of a heart attack. So we're going to start with a little video this morning that just kind of outlines the heart and the cardiovascular system, and we'll see if I can start this, and if not, Michael's going to help me. That's a good sign, and then that didn't work. We did this yesterday, and it worked. There you go. So I can't see it up there.
Your heart is a pump. It's a muscular organ about the size of your fist and is located slightly left of center in your chest. Your heart is divided into the right and left side. The division protects oxygen-rich blood from mixing with oxygen-poor blood. Together, your heart and blood vessels comprise your cardiovascular system, which circulates blood and oxygen around your body. In fact, your heart pumps about 5 quarts of blood every minute, and it beats about 100,000 times in one day. That's about 35 million times in a year. Oxygen-poor blood, blue blood, returns to the heart after circulating through your body. The right side of the heart, composed of the right atrium and ventricle, collects and pumps the blood to the lungs through the pulmonary arteries. The lungs refresh the blood with a new supply of oxygen, making it turn red. Oxygen-rich blood, red blood, then enters the left side of the heart, composed of the left atrium and ventricle, and is pumped through the aorta to the body to supply tissues with oxygen. 4 valves within your heart keep your blood moving the right way. The tricuspid, mitral, pulmonary, and aortic valves work like gates on a fence. They open only one way and only when pushed on. Each valve opens and closes once per heartbeat, or about once every second. A beating heart contracts and relaxes. Contraction is called systole, and relaxing is called diastole. During systole, your ventricles contract, forcing blood into the vessels going to your lungs and body, much like ketchup being forced out of a squeeze bottle. The right ventricle contracts a little bit before the left ventricle does. Your ventricles then relax during diastole and are filled with blood coming from the upper chambers, the left and right atria. Then the cycle starts over again. Your heart is nourished by blood too. Blood vessels called coronary arteries extend over the surface of your heart and branch into smaller capillaries. Here you can see just the network of blood vessels that feed your heart with oxygen-rich blood. Your heart also has electrical wiring, which keeps it beating. Electrical impulses begin high in the right atrium and travel through specialized pathways to the ventricles, delivering the signal to pump. The conduction system keeps your heart beating in a coordinated and normal rhythm, which in turn keeps blood circulating. The continuous exchange of oxygen-rich blood with oxygen-poor blood is what keeps you alive.
So just a thought about that since it came up. So for those of you who have atrial fibrillation, when they talk about blood clots that we're worried about, it's this top chamber right here, the atrium, that starts to beat at 300 to 600 times a minute, so the blood just pools up there. It's one form of heart disease. And when the blood's pooling up there, then you have a 5% per year chance of having a stroke. So if you have atrial fibrillation, it doesn't mean you're going to stroke. If we take 20 people who have atrial fibrillation and do nothing to them, 19 of those folks at the end of the year will not have a stroke, one will. That's the reason for putting people on anticoagulation, and that prevents this upper chamber from getting any blood clots. Also, one of the newer procedures that we're doing here at UnityPoint is the transaortic valve replacement. So we're putting in aortic valves from the leg. And as that video showed, the heart's electrical system runs right next to that valve right there. So you'll meet people who didn't have any electrical issues before they got their valve, but after they got their valve, because that area might be compressed when the valve is placed, they end up with a pacemaker. Beautiful. So as we discussed, cardiovascular disease is an umbrella term that describes diseases of the heart and the blood vessels, including both the arteries and veins. We're mostly talking about arteries today. There's a lot of people that have heart disease. So once you get above the age of 50, it's about 1 in 3. So even if you're here today and you don't know if you have heart disease, you got a chance of 1 in 3. It's over 81 million people in the United States have some form of coronary artery disease or atherosclerosis. For some folks who have familial hyperlipidemias, which is a genetic high cholesterol, it can start in their teens. For a lot of the rest of us, it's a disease process that begins as we get into our 40s, 50s, and 60s, and it has a lot to do with genetics, but also with the Western diet and Western civilization. We tend to be a bit more sedentary than we were 100 years ago. Like it says there, it's often called coronary artery disease, but we're really talking about cardiovascular disease. So once your body starts to layer your heart arteries with fat and cholesterol, it's not just putting them in any one spot. It's actually layering the arteries from head to toe with fat and cholesterol. And you'll only feel it or notice it in the areas where the blockage has become more than 70% blocked. So if you're sitting on a 40% narrowing, your heart doesn't know it's there. Coronary artery disease is the most common form of atherosclerosis. With over 17 million Americans who live with it, it oftentimes will result in weakening of the heart muscle, which is congestive heart failure. High blood pressure often precedes it or is there in conjunction with it. And a lot of these diseases, whether you're talking about blockages in the neck arteries, carotid artery disease in the heart arteries, or coronary artery disease, or peripheral artery disease in the leg arteries, the treatments for a lot of this stuff is the same. The causes are also, a lot of the causes are the same as well. The most common known symptom for blockages in the heart arteries is angina. So angina pectoris is really just a term that angina is pain and pectoris is chest. So it's pain in the chest. That only occurs in about 1 out of every 3 people that present with heart disease. So it's not as simple as we just wait until somebody shows up with chest pain and then we do some tests on them. People have to be aware that the symptoms can sometimes present quite atypical. As an example, I had one gal who was in her early 50s that I'll never forget. She had a strong family history for heart disease, pretty athletic, and she presented because every time she exercised, well, she was worried about her family history, but every time she exercised, she got a little bit of pain in her thumb. I mean, I still remember my thought at that time was that, well, this isn't heart. I mean, I don't know what it is, but it's not heart. So we did a treadmill test on her, and she flunked it, and she got pain in her thumb. When we did her heart catheterization, she had a blockage, a widowmaker actually. We fixed it, and her exertional thumb pain went away. So, you know, why she was wired like that, I couldn't tell you, but that was her. Now, chest pain is often, like, this happens all the time. I'll come in and say, are you having any chest pain? And somebody will say, no. But then they'll say, well, but I get this heaviness. So it doesn't have to be chest pain. The discomfort that people talk about can be in the jaw, be in the neck, the shoulders, it can be in your thumb. Of course, it can be in your chest and it can be in your arms. It can be described as a heaviness, a tightness, a pressure. It can be described as aching. It can be burning like people get with reflux. It's very common for folks to think that they have a stomach problem or ulcers when they really have a heart problem. True heart burn. People can also feel numbness or fullness or a squeezing sensation in the chest. Lack of blood flow to the heart muscle can also cause palpitations or flutters because it can cause the heart muscle to get irritable and to start to fire off irregularly. There's other common symptoms also that aren't angina pectoris or chest pain or discomfort. There's also shortness of breath that people describe, and that can be considered what we call an anginal equivalent. Palpitations, like I talked about. Most people at some point in their lives get palpitations. You feel a fluttering in your chest. 9 times out of 10, it's nothing, it's normal, it's common. Too much coffee, maybe out a little bit too late the night before. It's a flip-flop feeling in your chest, but it can also be a marker for heart disease. Especially with sedentary folks, a faster heartbeat can be a sign that you're getting impending trouble with your heart. As an example, people that run marathons often have a slow heart rate. The heart adjusts to the need for more blood flow. If you're sedentary and out of shape, oftentimes your heart rate will be faster, often in the upper 80s, 90s, even low 100s. Dizziness and lightheadedness or near pass-out spells or a true pass-out spell is a bad sign if it's from the heart, so you definitely want to get seen by your physician. Most folks will present to an emergency department if they're having that type of trouble. Nausea and vomiting can be from the heart if somebody's having a heart attack. It's quite common for folks to feel nausea along with their chest discomfort and perhaps to even have vomiting. Things that we'll talk a little bit more about that's actually come to light over the last 10 to 20 years. Some folks don't get any of these symptoms at all. Makes it very hard to diagnose. Fatigue and tiredness and weakness are super common markers for heart disease. Most of us blow this stuff off as, I'm aging, I'm older, I've gained 20 pounds. But if you have noticed over a short period of time that you are more weak, tired, even sleeping more, that can be a sign that your heart's starting to struggle with blockages. Profuse sweating a lot, especially at rest, or what we call diaphoresis, is also a sign of blockages in the heart arteries. Oftentimes that's what we see in folks that present with heart attacks. but it can also be a marker for a severe blockage, usually one that's over 90%. Of course, any of these symptoms, and you want to make sure to get in to see your healthcare professional, whether that be an advanced practice practitioner, your primary care physician, or if you've got a cardiologist, you would certainly want to let them know, especially if there are any changes. We also tell folks if you have nitroglycerin tablets, if you've got known coronary disease, you take a nitro tablet once, twice, maybe 3 times, once every 5 minutes, and if your discomfort doesn't get better, then you call 911, because by definition, then if that's your heart, you're having a heart attack. Anybody that gets chest pain, though, if you call your physicians usually, they're not going to diagnose you over the phone, or at least they shouldn't. So usually they'll tell you that you're going to have to go into the emergency department. Most physicians don't even want to really see you in the office, because if they do that 100 times and have somebody come in the office, they're going to catch 5, 6, 7 people that come into the office with heart attacks, and that's not anything anybody wants to deal with in the office. Signs and symptoms in women, this isn't just for women really. I mean, this also goes along with folks that are a little bit older. Chest discomfort becomes less reliable. In common, women tend to get coronary disease 10 years later than men. It used to be thought that this was basically a hormonal difference, although it's much more complex than that. We used to think, I can remember when I got out of training, we used to think it was mostly estrogen based. We put everybody that came into the office, we made sure they were on estrogen, because there were some big studies from the National Institutes of Health that said that if you take estrogen, you're protected. Then they did a bigger study in the early 2000s that showed, estrogen actually causes heart attacks. So then we were pulling a bunch of women off of estrogens, causing menopausal symptoms left and right, and I remember that. So some of this stuff's pretty complicated. Women's symptoms, though, tend to present differently than men in that there's more fatigue and tiredness described, more palpitations, less chest discomfort. So in the Framingham studies and some of these bigger trials where they looked at 40 or 50,000 people, when they broke it up between men and women, women's complaints were statistically different than men's. A lot of the stuff has been gender-based over the years. The reason that we know that treadmills work, that we can put you on a treadmill and run you and we can diagnose a blockage, is because of studies that were done in the 40s, 50s, and 60s on military recruits who were then followed over the subsequent decades. Well, the majority of those people were men. And so a lot of these studies initially were, it wasn't realized, but it didn't necessarily cross over to women. So we still do treadmill tests a lot, standard treadmill tests. They're cheaper, they're faster, they're less invasive, but they are also more predictive in men, less predictive in women. So we have to treat men and women a little bit different when we're trying to diagnose heart disease. So shortness of breath, weakness, and unusual fatigue means it's come on kind of quick. So it's not like, I'm more tired now than I was 20 years ago. You know, you can't walk as far now than you could 6 months ago. That would be a sign that you might want to see your physician. Just like men, women get nausea and dizziness. Chest discomfort complaints are less likely to be upper chest, left arm, more likely to be lower discomfort. That's why oftentimes it'll get missed. Initially, somebody will get put on reflux precautions, acid reflux medications, etc. The upper abdominal discomfort does feel more like indigestion, and back pain is not uncommon as well. So the most common presenting symptom for women is actually fatigue and tiredness. For men, it's number 2. For both, chest discomfort is number 3. So that is not the most common one that we see. Now you can always learn more on the internet, right? We all go to Google University now to learn stuff. And there's a ton of stuff on the internet, but what you want to remember is the stuff that's not marketing or advertising or stuff that you can probably count on. Not all of us believe you can always count on the government, but the National Institutes of Health, NIH.gov, has some excellent sites on all of these situations and diseases. So if you go to NIH.gov and search any of these, such as subtle and dangerous plus heart, they've got some good information there. There's also things like heart.org, which is on another slide. Diabetes, heart disease, and stroke go together. So I like to think of the 5 basic things that we all need to think about when we're trying to make our heart health better, the A, B, C, D, and E of treating heart disease. So A, stands for aspirin, which is in and of itself kind of an interesting topic nowadays. B stands for blood pressure. C stands for cholesterol. D stands for diabetes. And E stands for exercise. Aspirin's an interesting topic nowadays because we used to put everybody on aspirin who was at risk for heart disease. Then just had a big trial come out in 2018 which shows that it's not necessarily helpful for everybody. So when you take aspirin, there's always a risk that you got a higher chance of bleeding. You know, if you cut yourself and you bleed a little bit, who cares? Bleed into your leg, not a big deal. Bleed into your head, that's a bad day. So what they found out is that if you know that you've already got heart disease, if you've been diagnosed by your physicians, that's called secondary prevention. And for secondary prevention, everybody should be on low-dose aspirin. Primary prevention, where you're just somebody that maybe has a family history, maybe you've got high blood pressure, but no known coronary disease or blockages in leg arteries, neck arteries, that kind of thing. Primary prevention, it was equivocal. So it wasn't the study didn't come out in favor of aspirin, it didn't come out against aspirin, and probably because of the slight bleeding risk that you take on when you take an aspirin. So my practice right now, if somebody's already on aspirin, I don't take them off no matter what. But I'm not putting people on standard aspirin just because anymore. I'm 56, I've got a family history of coronary disease, I've been taking aspirin for a while, I still take it, knowing what I know. Because I know they're going to come out with another study in a few years and it's probably going to be different. But that's where aspirin stands right now. As far as blood pressure, they just came out with the new guidelines for blood pressure, and those guidelines suggest that everybody should have a blood pressure below 120/80. Well, if we're going to do that, then we're going to have 3/4 of America on blood pressure medicine. That's probably not a great idea, and you got to keep in mind a lot of these studies are funded by pharmaceutical companies. So I'm not yet treating everybody to get their blood pressure below 120/80, but we will have discussions with folks about making sure that they're more aggressive with diet, exercise, losing weight, that kind of thing. C is for cholesterol. The cholesterol guidelines have been around for quite a while. We usually want certainly your cholesterol below 240. 200 is a better number, and then if you have heart disease, we need to have it even lower than that. A lot of studies initially, back in the 80s, 90s, showed that if you got the cholesterol too low, you actually had an increase in mortality, higher chance of dying. Well, now they've done newer studies which show that's not the case. So the current guidelines are get it as low as you can. And there's some new medications that are out. One that just came out is called Juxtapid, which is a monoclonal antibody. It's supposed to be only used for people with familial hyperlipidemia, in other words, genetic, and their cholesterols are 500 or above. But there's going to be a lot of this new stuff coming out. That medication only costs $300,000 a year right now, but as others come out and generics start coming out, it'll be down to the prices that we get now with pills. D is diabetes, and that's a whole other topic, but I just like to keep in mind, because I'm kind of a simple guy, get your hemoglobin A1C below 7. That's what you want. And then E is for exercise. Most of us don't exercise enough. And exercise doesn't mean that you have to be silver sneakers, or you have to go to a gym, or you have to get on a treadmill, or you have to bench press 200 pounds. It means do a little bit more than you're doing yesterday. So for folks that don't exercise, even just walking 10 minutes in your house, doing some chores that you don't usually do, anything that burns a little bit more of the calories will make you healthier, less sedentary, and it's been shown to decrease inflammation inside the artery. So it's a big deal. Sitting around increases inflammation. Sedentary lifestyle probably has a lot to do with some of our issues in Western civilization. So how do we diagnose it? So you go to your doctor, they do blood tests. Does everybody get a treadmill test or some kind of a stress test? No. Your healthcare professional initially will talk to you. We'll see how you're doing. If you're feeling great and you've got no symptoms, they may choose to do nothing. But you need to be really honest with them. You know, a lot of folks will come in, they don't really want to have anything done, they don't really want to bring things to light. You need to be frankly honest with them and tell them if there's any fatigue, tiredness, shortness of breath, chest discomfort you've had. Let them decide whether or not they think that you've got an issue. Your physician will look at your risk factors. You know, do you smoke? Do you have high blood pressure? Are you overweight? Are you, I don't like the term, but are you obese, which means more than 20% even above heavy? What's your cholesterol? Are you diabetic? What are your genetics? All this stuff will be taken into account. Every single one of those risk factors increases your chance of having blockages in the heart arteries by 2 to 3 times according to the studies. So if you smoke and you got no other issues, your chance of having a blockage in a heart artery is 2 to 3 times what it would be if you didn't smoke. If you smoke and you're diabetic and you're hypertensive and your cholesterol is 300 and your family history is that everybody gets blockages before the age of 50, you start stacking those up, do the math, you can push yourself up to above 50%. You're going to get something. One thing we used to say, if you're an insulin-dependent diabetic, in other words, if you got it when you were young and you smoke, I haven't seen anybody yet that does not come in with heart artery disease by the time they're 45 or 50. So you just have to know your personal history, what your risk factors are, and your physicians or your practice providers will help you do that. And then they'll do a physical exam on you, certain diagnostic tests and procedures based on whether or not you've got any issues. So there's lots of different blood tests that they can do to diagnose heart disease. We have lots of cardiac biomarkers now, troponin, creatine phosphokinase, all kinds of fancy stuff. Those are usually done to diagnose a heart attack. We don't see those in the bloodstream unless there's death of heart muscle. So there's got to be leak of the interior components of the heart muscle cells. They'll often do lipid blood tests, and when they do your lipids, they look at your cholesterol, your total cholesterol, but they also look at your triglycerides, your low-density lipoproteins, which are the bad cholesterol, your high-density lipoproteins, which are the good cholesterol. Homocysteine and Fibrinogen tests kind of come and go. Some physicians will do them, some don't. They're markers for inflammation. So if your physician does a homocysteine test and it's elevated, that means you've got inflammation in your body, and that's interesting, but we don't know what to do about it yet. So for a while, we were putting people on folic acid. So everybody would get folate, 1 milligram. And then the bigger studies came out which showed that it doesn't really help. C-reactive protein's the same, is another marker of inflammation. Blood tests for anticoagulants will be done if you're on anticoagulants. Of course, they'll test your blood for sugar, and if your blood sugars are elevated, they might do a hemoglobin A1C to see if you've got early diabetes. B-type or brain-type natriuretic peptide is actually in several different tissues in the body, but it is in the heart as well. It's mostly associated with congestive heart failure, so that's the test we'll do on you if we think you've got a weakened heart muscle. When we put you on appropriate therapy, that level of B-type natriuretic peptide will go down, so we can actually measure your level of heart failure. We usually check your magnesium and potassium levels because those are very important for the heart's conduction system. And your blood counts are also usually included. There's certain cardiac diseases like sarcoidosis, amyloidosis, and some of the cancers that can cause a weakened heart muscle. And sometimes we'll get a heads up about that by an elevated blood count or a low red blood count. So some common tests and procedures. Your doctor can do an electrocardiogram or an EKG right there in the office. They hook you up with leads across the front of your chest, and we can tell the right and left side, and we can tell if there's been any damage. We can tell if your heart's thickened. We can tell if there's any conduction abnormalities. We can do stress tests, and those are can be anywhere from the standard treadmill test or functional test where we just run you on a treadmill, and we're shooting for a certain heart rate, which is 220 minus your age times 0.85. Or we add things like an echocardiogram, a nuclear scan, which actually looks at the blood flow to your heart. When we do a functional stress test and we're trying to diagnose a blockage, it's only 70% accurate in people that have chest pain. So it's a great screening tool, but it's not all that in a bag of chips. When we add echo or nuclear to it, we get up to about 95%. So you can still miss 1 out of 20. The other side's also true. So if you have blockages in heart arteries, and we do a stress test on you, and you get that phone call that says, oh, it's normal, it's great, it's still a 5% chance that test is wrong. It's really a stress test. They're gonna walk you. If you don't have any orthopedic limitations, we walk you on a treadmill. Usually it goes 6 or 7 minutes. Some folks only go 3. Folks in good shape will go 10 or 11. If you have orthopedic limitations, have trouble with balance, or you can't walk on a treadmill, or you just don't want to, we have chemicals that we can infuse into the veins that cause the heart arteries to dilate. It's not a true stress test. It's often called a stress test, but what it really does is it dilates the heart arteries. Blockages in heart arteries don't dilate. So then we can see on the scan areas of the heart muscle that aren't getting enough blood flow. And that's how we diagnose blockages with the chemical stress tests. You can go to places like heart.org, tons of videos on YouTube which will show you all this stuff. Most of it's pretty accurate, not all of it. So something that's not talked enough about, and I have personal experience with this. So I'd say about 2.5 years ago, I was 30 pounds heavier than I am today. And my physician, who I don't like to go to doctors, I don't really like doctors. I'm in there and I know I'm heavy and he's telling me I'm heavy and I'm not liking to hear that. They get my blood test back and for the first time in my life my cholesterol's high. My blood pressure's, it's been trending higher for a couple years. And he wants to put me on medicine for blood pressure and for cholesterol. And I'm not much of a pill guy. I'm like, you know, to be honest, they didn't talk to me about diet and exercise and stuff. They just probably figured I knew about that, which I do. But oftentimes that gets missed in the office, and we have to make sure as professional, as care providers, that we talk to folks about that. The initial guidelines are supposed to be that we take 3 to 6 months, tell somebody, take 3 to 6 months, lose some weight, start walking, and we're going to retest you and see if you can get it down on your own. I dropped 30 pounds, cholesterol levels dropped back to normal, and my blood pressure is back to normal. Am I going to get it eventually? Yes. And I'll eventually be on meds, but not right now. And everybody here can do the same. And we'll talk about some of the things that you can do to get your levels down so that you're not just having to take more and more pills. And we see people in their 70s and 80s come in, they'll be on 15 pills, 20 pills. You know, you go to this doc, gives you these medicines, another doc gives you medicines, and some of this stuff you can really make a big dent in the disease process by just changing your lifestyle a bit. So I wanted to mention some of the foods that I like to think about. Foods that are high in fiber, foods that are monounsaturated fatty foods that help people to get their cholesterol levels under control and have been shown to improve blood pressure. These foods actually, if you eat enough of them, they've been shown to relax heart arteries and to help decrease the amount of fat and deposit inside the arteries. So these foods include avocados, high in monounsaturated fats, fatty fish, salmon is the one that comes to mind first off. Things that have a lot of fiber in them as well as fats are really good for you too. You don't want to eat a pound a day, but nuts have a lot of good qualities to them. If you cook, olive oil is probably the best. Extra virgin simply means it's a monounsaturated fat, so if you use that, that's why Mediterranean diets probably work too. They use a lot of olive oil. And then one that my personal favorite that I love to talk about is coffee. So if you drink a lot of coffee, you're going to be a little bit jittery, and I like coffee. They have never done a study, and they've tried. They've never done a study that has found that coffee is harmful. Now it'll make you jittery. If you've got a fast heart rate, it'll make that worse. That's the caffeine component. You can drink decaf. But coffee itself is an antioxidant. And some of these foods also have a lot of antioxidants in them. And these antioxidants prevent inflammation. So there's a lot of work going on trying to define how much of some of these can we take and decrease our chance of getting blockages in arteries. They don't know yet. Oftentimes, they don't work if you take them in pill form. You'll see all these advertisements for pills that do this or do that, pomegranate juice, turmeric, some of this stuff, it's unproven. So that's why we don't use it as a medicine, but as a nutraceutical, probably doesn't hurt you to take turmeric pills. And it doesn't hurt you to have, there's a study that just came out a couple years ago that showed that people that drank 3 cups of coffee a day had less coronary disease than folks that drank none. So I like to hang my hat on that because I like to drink 3 cups a day. Works for me. You want to be active. Just walking is better than anything else. You can count on burning about 100, just on average, 100 calories per mile walked. And if you're burning 100 calories and you do that once a day, if you did it 7 days a week, 30 days a month, that's going to be about 1 pound a month. The average person gains, when they're gaining weight, 3 to 5 pounds a year. That's why it sneaks up on you. And you look back and 5 years later you're up 20 pounds. You're like, where did this come from? It's coming on slow. So try to be more active. Smoking is a big deal. Smoking causes inflammation. Besides the fact that it's super expensive now because they tax the bananas out of it. So quitting smoking is a big deal. Like I showed with my personal example, losing weight's a big deal. If you're hypertensive, if you've got high cholesterol, if you've got diabetes, sometimes you can stop all of that for a while. You're still predisposed to it, but you can stop it for a while by dropping some weight. And I've seen it happen for folks even just losing 5 pounds. Easier said than done, but it does work. So your providers are supposed to talk to you about diet and exercise therapy for 3 to 6 months before they just slap you on a medicine. Now that's different if your blood pressure is 200 over 100, then you need therapy. But if you come in and you're consistently 140 over 90, you've got time. You're not going to have a problem from that type of high blood pressure, 150 over 95. It's not going to cause you trouble tomorrow, next week, next month, probably not even next year. 10 years down the line is when the problem starts. Relaxation techniques do work. So for folks that believe in yoga and behavioral science therapy and things like that, it does work if you do it. There's lots of studies out there that show that relaxation helps to drop blood pressure, even can change probably through the drop in blood pressure and some other mechanisms can change your blood counts, your cholesterol levels, all kinds of stuff. So it's something to consider. So as I said before, you can learn more on the internet. Here's just some sites, mylifecheck.heart.org. I love the National Heart, Lung, and Blood Institute, NLBHI. They've got National Institutes of Health, tons of information. Heart.org. You can go to the American College of Cardiology sites. Tons of stuff. And for those that smoke, just keep in mind, the highest chance for quitting smoking truly is by quitting cold turkey, and that's not easy. The highest percentage is with folks that go into a smoke enders program, take some kind of an assist, which may be nicotine gum, or it can be Chantix, you know, the slow turkey thing. But if you're in a smoke enders program that gives you the support, and then you take some type of assist to get you past the, you know, the feeling that you want the cigarette, those folks have sometimes, if they're motivated, as much as a 70% chance of quitting. And if you don't, you know, you never fail until you stop trying. So if you don't get it the first time, you just keep trying. These are some of the medicines that are commonly used to treat coronary disease. We won't go through these in detail, but the antiplatelets, if you have a stent, they'll put you on dual antiplatelet therapy now. Stents were initially bare metal, and we put folks on 2 weeks of therapy. Dual antiplatelet therapy means aspirin plus something else. So it's usually either aspirin plus Brilinta nowadays or aspirin plus Plavix is the generic. 15% of people are non-responders to Plavix. That's why we like Brilinta better. Brilinta costs $450 a month for most folks, unless you got the insurance that covers it. Plavix is, for some people, $4 a month. They've done studies on Plavix. They've taken these people that they can test it in the blood. This person's a non-responder. You would think they'd have a higher chance of clotting a stent off. It's not true. So they haven't figured out why that's a deal, if it is at all. So for us, if somebody comes in with a recurrent blockage who's on Plavix, we might test them as a non-responder, and if they're a non-responder, then we would not put them back on Plavix, but it's not because it's black and white at all, it's a gray area. Dual antiplatelet therapy now, because the stents are coated, they've got chemicals on them that stop scar tissue formation, whether that's everolimus, zodorolimus, it used to be paclitaxel, which we don't use anymore. You need to be on antiplatelet therapy for a minimum of 12 months. And they keep looking farther and farther out. Some studies now suggest 18 months. It's probably better to be on it longer if you have a stent. If you need surgery, they can usually take you off the antiplatelet therapy for a couple of days, if not a week, and your risk is not zero that the stent will clot, but it's not really high. If you come in with a heart attack right now and you're on no medications, your doctor's going to slap you on 5 different things. You're going to get the antiplatelets, you'll get ACE inhibitors like lisinopril or the angiotensin receptor blockers like losartan, the ARBs. You'll get a beta blocker because that reduces your risk of sudden death. Usually you won't get calcium channel blockers unless you've got other blockages because they don't really do anything for the heart muscle. They just help to dilate the heart arteries. You'll be put on a lipid-lowering medication. There's a whole bunch of them out there, the statins. The ones that have the most study behind them, the ones that have been shown to decrease heart attack, stroke, and death the most is Lipitor and rosuvastatin. So at least here, if somebody comes in that's not already on a statin, we'll put them on high-dose Lipitor therapy because that decreases their cholesterol, also decreases inflammation. And then nitrates also, they're just dilators, so they don't decrease your risk of future heart attack, but they'll decrease chest pain if you've got other blockages. This is video number 2, and this just shows an angioplasty stent procedure. And this one I think I'm going to get.
Coronary angioplasty, also called as the percutaneous transluminal or balloon angioplasty, is a treatment procedure to restore the blood flow in the narrowed or blocked coronary arteries caused due to clots or blood clots. Most coronary angioplasty procedures last between 30 minutes to 3 hours. Once the patient is admitted, his heart is monitored and is given an intravenous sedative to relax the body. A needle is inserted through the wrist into the radial artery. A guide wire is then passed through the needle and is guided through the arterial system up to the heart. A flexible catheter is slipped over the wire and threaded up to the heart. This is monitored using a continuous X-ray imaging device called fluoroscope. At this point, the guard wire is removed and the tip of catheter is positioned to enter the coronary artery. A special dye is injected which allows the fluoroscope to take X-ray images of the arterial interiors and help in identifying the position of the block. This is called angiogram. Once the blockage is identified, a flexible guard wire is inserted into the artery vessel, followed by a balloon-tip catheter over this wire to position itself at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, re-establishing the flow of blood in the artery. After the blocked vessel is reopened, the deflated balloon catheter is withdrawn from the artery. The same treatment procedure is repeated in the case of multiple blockages. Most patients may also receive a coronary stent, which is a small tube made of wire mesh designed to keep the artery open once it has been treated. A collapsed stent is placed over the deflated balloon catheter as it is inserted into position. When the balloon is inflated, the stent expands and locks itself into place. The deflated balloon and catheter are withdrawn, leaving the stent behind to hold the artery open permanently. Post-treatment, a pressure bandage is applied over the radial artery to prevent bleeding. One will need to lie down for several hours, during which signs of bleeding or chest pain will be monitored. The patient may either be discharged on the same day or after an overnight stay at the hospital.
Those are from our friends at Fortis. So that used to be a big deal back in the, I'm fortunate enough that I've been in medicine from the beginning of stents. I can still remember the Kaiser Permanente cardiologists, because they were always concerned about, I mean, they were the forefront of cost containment and such. They thought that metal tubes inside heart arteries were the dumbest thing they'd ever heard of, and it was never going to happen. Found out not to be true. We used to have heart surgery, open heart surgery backup for every procedure that we did. We didn't used to have stents, so when you do a balloon angioplasty alone, all you're really doing is stretching the artery and cracking the plaque, and you're causing a lot of damage. The body usually heals it, but not always. And so a lot of times we were crashing people into the open heart surgery theater to have open heart surgery because the angioplasty had failed. Nowadays with the stents, the risk of anything going wrong with these procedures is well under 1%. And so it's become quite a kind of a safe and everyday procedure where you do go home same day if you get a stent and it goes without any complications. So all we're really doing with a stent or with angioplasty, when we can't fix your arteries with medicines, diet and exercise and such, we can go in there, and there's lots of different devices. We actually have devices that are atherectomy devices. We can actually cut out some of that fat and plaque. But the majority of folks get a stent, and all the stent does, it's got a lot of radial strength in it. So once we open it, it stays open, and it pushes all that crud out of the way. Doesn't get rid of it, And one of the risks of the procedure is breaking some of that off and it goes downstream and plugs things, which doesn't happen often, but it's not a good day when it does. But that's right there at the bottom. That's what we do. We just push it out of the way and we restore, we take out that blockage, so we restore full blood flow down the artery. Your heart muscle doesn't care that the fat and cholesterol is there. It just cares if it's not getting enough blood. It's not getting enough gasoline to the engine. So we restore full blood flow back to the heart arteries, or to the heart muscle. Another option which is less common these days is bypass surgery. So for folks that get coronary artery bypass surgery, or what we call CABG, C-A-B-G, you basically plan a detour or a new road around blockages. So when they're in there, they'll try to bypass all the major heart arteries. There's 3. So folks will often talk about a 3-vessel bypass, but if there's lots of different blockages, sometimes it'll be 4-vessel, 5-vessel. We used to do some that were 6 or 7. Nowadays they tend to do only 2 or 3 because we don't want people on the heart-lung machine long. The longer you're on the pump, higher the chance that you'll get stroke or complications from the procedure. Sometimes nowadays we do hybrid procedures where you'll get 1 or 2 bypasses and then we'll go in and put a stent in an artery that's easier to get at with that technique. The same things that warn you that you've got blockages will pop up if you have a heart attack. They're just usually worse. Not always, but usually. So chest pain or discomfort, shortness of breath, and then the other signs we talked about, tiredness, fatigue, sweating, nausea, and vomiting are big ones as well. That concludes today's talk. I appreciate everybody's attention. And if you have any questions, be delighted to take them. If you have a question about something, there's probably several other people in the room that have it as well. So thank you for coming.
What year